So 2024 pharmacology test 2. Question 1. Renal damage is a potential adverse effect of aminoglycosides. In one part of the kidney are aminoglycosides retained. Now, should, kindly advise what should we do? Okay, let me first finish reading the question so that we are not disturbed. Renal damage is a potential adverse effect of aminoglycosides. In what part of the kidney are aminoglycosides retained? Which causes this effect? Loop of Henle, distal tubule, glomerulus, proximal tubule. What I saw with this paper is majority of the questions are from antibiotics, yeah, majority of them. So which one should we do? We first talk a bit about antibiotics and then we start answering the questions, or we can just be answering people we've already read. I think maybe in 2 minutes we talk about antibiotics and then continue answering the questions. Which one is which? All right. Okay. So when it comes to the antibiotics, we know antibiotics better they should be called antibacterials because we are talking about drugs that are going to be working against bacterial infections. So we classify antibiotics in three many categories. We are going to have those antibiotics that are okay. First, the classification. So we can classify antibiotics depending on the mechanism of action. Number two, we are going to classify them on the spectrum of activity. So I'll just put spectrum of activity. Are you talking about them being broad spectrum, or they are really restricted to a certain species of bacteria? And then you can classify them depending on the mode of action. Now, if I write MOA again, it will look like that. So mechanism of action and mode of action are different. So this is a mode, and then I can put of action. Okay. So when we start with the mechanism of action, how are they working in order for them to be able to defend us or to deliver us from those bacterial infections? So there are five basic mechanisms in which these ones are going to be working. The mechanism of action. Number one, so all these are going to be inhibiting. On the mechanism of action, it's all about inhibition. So you have got those that inhibit the synthesis of the cell wall. So you have got cell wall synthesis inhibitors. Remember, bacteria have got cell walls. So cell wall synthesis inhibitors. And specifically, what classes of drugs are you going to find here? Here, you are going to have drugs like the penicillins, the cephalosporins, and you are going to have other classes of drugs like the carbapenems and those others. And then, besides you working on the cell wall, because bacteria also have got other parts, they also have a cell membrane. So you have got also cell membrane synthesis inhibitors. And then, besides that, you are also going to have those that are going to go a bit deeper in the cell, those that are inhibiting the making of proteins. Remember, when a bacteria enters our body, it's going to make these proteins that is going to be able to use to fight against us so that it can cause infection. So you're having drugs that will be preventing the making of those proteins. So protein synthesis inhibitors. And then apart from proteins, you are also looking at those because before you can make proteins, the central dogma of molecular biology tells us that we're going to have DNA going into mRNA, mRNA then to proteins. So you can have those that are going to be inhibiting the synthesis of nucleic acids, the DNA and the mRNA. So I've got the nucleic acid synthesis inhibitors. And then the last one, you have got the folic acid synthesis inhibitors. Folic acid synthesis inhibitors. Okay. So that is a basic classification. Now, when you look at, as we have said, for the cell synthesis inhibitors, we have got many the penicillins, the cephalosporins, the carbapenems, monobactams, these guys. And then for let's go to cell membrane, not that much because even our bodies have got a cell membrane. So these drugs that will be working on the cell membrane, they can as well they will be bad also for us because we also have a cell membrane. And then you go on protein synthesis. The protein synthesis is good because in our bodies we have got a ribosome. Specifically, it has got two subunits. The large ribosomal subunit is 40s, the small is uh actually the small is 40s, the big is 60s. Just be adding 20. So 40 plus 20 is 60. And then when you combine these two, are going to get 80. So you just add here 20 to 60. It's not mathematics. For bacteria, reduce all the numbers that I've said by 10. So the small subunit is 30s, large subunit is 50s. If you combine them, it will be 70s. So because we have got different subunits in human and in bacteria, you can really use these. So the protein synthesis inhibitors, and examples that we have there, we have got tetracyclines, aminoglycosides, macrolides. At least these three big groups, please take note of them. Actually, there is a mnemonic that you can use, MALT. So the MALT, that is the protein synthesis inhibitors. M is representing macrolides, A is aminoglycosides, and then L, there is what they call lincosamides. Not that common. And then T is the tetracycline. So macrolides, aminoglycosides, tetracycline. One thing that you should know about every time you hear of aminoglycosides, always think of ototoxicity. They cause problems with the ear. That's the big side effects of aminoglycosides. Again, the next one, nucleic acid synthesis inhibitors. When you're talking about this guy, think about those guys that have got a sulfate in them, like the quinolones. So using quinolones, there is another drug, other classes of drugs which are made coming from this. They are known as fluoroquinolones. So I've got fluoroquinolones, and then you are also going to have these which are inhibiting folic acid synthesis. Specifically, you have got two that we really need to know. You have got sulfonamides, and then you have got also trimethoprim. So quickly, just something that we need to understand. There, I have not written something on cell. So we are saying penicillins. Besides penicillins, we have got cephalosporins. We have got also the carbapenems and these others. Okay, so just to say something very short on these classes. Now, I've not mentioned anything to do with this classification. So mechanism of action, and then we are talking about the spectrum of activity. On the spectrum, you have got those that which are going to be narrow spectrum and those which are broad spectrum. Most of them are broad spectrum, but the penicillins, them they are mostly narrow because they are specific to gram positives. But for there are other classes of penicillins which were made, which work now to the broad group. But the initial ones like the pen G is narrow, right? But they have been extended. So we have got what they call extended spectrum. So we mentioned something about them. When it comes to the spectrum of activity, those which are broad, mostly the tetracyclines, those are going to be broad, and majority of them are actually broad. And then for the mode of action was saying, how do they kill bacteria? How do they prevent these infections? So I've got those which kill and they'll come direct and kill the bacteria, and then you are going to have those that are going to prevent the growth of the bacteria. So I've got bactericidal and bacteriostatic. Now when you look at those which are bacteriostatic, they are just going to prevent the growth of the bacteria. I've got tetracyclines. Remember, the tetracyclines are working on what? Proteins. So they are preventing the making of proteins, and so they will prevent the growth of the bacteria. Those are bacteriostatic. Also, you are going to have some other classes that are falling in these other groups. And then you are for the bactericidal, those which are preventing the synthesis of the cell, or they are going to be able to kill the bacteria. And then those which are preventing the synthesis of some of these which are preventing the synthesis of protein, like the aminoglycosides, they are bactericidal. So now a quick on these classes. For the penicillins, what I want us really to understand, penicillins, please take note of this. Penicillins and cephalosporins, they have got a similar structure. They have got what we call a beta lactam. Beta lactam. So because they have got a beta lactam, mostly you want to expect that they behave the same. So if you have got a drug, let's say if the penicillins have a bad side effect and you want another class of drug you can give, don't go for the cephalosporins because they are more likely to give that same thing because they have got the same structure. So for the penicillins, the first one, so how do these guys work? They are going to bind to what is known as transpeptidase. This transpeptidase is going to prevent the making of peptidoglycan, which is part of the cell wall. That is basically how they work. You have got pen G, which is going to work for against gram positives. It's narrow spectrum, and this one specifically, it is susceptible to penicillinase. Remember, penicillin is a drug working against bacteria, but the bacteria produces enzymes to fight against the same drug that you are giving. So bacteria is producing a enzyme, penicillinase. So pen G is actually susceptible to that. So for those bacteria that have got pen G, I mean which have got penicillinase, they will not be pen G or penicillin G will not work against them. One problem when it comes to these penicillins is hypersensitivity. That's the biggest problem. And then there's another class which was made, not really a class, but another drug which was made is pen V. It is more similar to pen G, but it's just that it's better when it comes to absorption. So it is better when it comes when you just give it orally, it is going to be better than pen G. But most of the properties are the same. So those were the first ones. And then you have got what they call penis. Since pen G and pen V, the ones we are saying, they can be killed by penicillinase. So I've got what we call penicillinase resistant penicillins. Those that are not going to be killed by penicillinase being produced by your bacteria. And you have got two that is are of importance. You have got methicillin. Methicillin is a bigger one, but methicillin they normally don't give it because like it has got some GIT problems. Actually, it is not acid stable, and so because of that, you can't give it orally. You should give it IV. So drugs, those bacteria that can be killed by methicillin, you call them methicillin. What's the word? So they are not resistant. So you have got methicillin resistant stuff, and then I've forgotten the word for. Thank you so much, Doc, for that. Susceptible. So those guys that are susceptible to methicillin, instead you are going to be giving some other drugs like cloxacillin. They are going to be ending in sacillin like that. So that's another drug. Those we call them penicillinase resistant, but they are methicillin susceptible. Besides that, the penicillins, you have got those which are extended. So when it comes to cloxacillin, it is better than methicillin because it it cannot be destroyed by the acid in the stomach, and so can give it orally instead of only IV. You also have the penicillins that are extended spectrum. They work against a lot of different bacteria. So of those, we call them amino penicillins, and there are two amino penicillins, ampicillin and amoxicillin. You can say they are all having an A. So ampicillin itself is more, ampicillin is better against the strep viridans and enterococcus. You know, strep viridans, these are the guys that cause problems that have to do with dentition. So, because of that, ampicillin is going to be good for those people that have got dental infections. But the problem is that after you take it orally, it causes diarrhea. That is ampicillin. And then amoxicillin is even better. It will actually do more the same like ampicillin, but there is a reduction in the ability to cause diarrhea. That is amoxicillin. Amoxicillin. So how are you going to remember ampicillin and amoxicillin? Anyway, you remember ampicillin. Don't forget for that diarrhea. And then, so those are the amino penicillins. I think that's enough on the penicillins. Just something again on these other classes. So you have got these other drugs that have, we have said that penicillins and cephalosporins, but they are not the only ones. You have got other classes of drugs that have got this beta lactam. So what happens is that there is also an enzyme that the bacteria produces to fight against this beta lactam ring. So you call it beta lactamase. So you want to give, so that's a problem because for the penicillins, they can be destroyed by the beta lactamase produced by the bacteria. So we want to give those drugs that are going to be resistant to the beta lactamase. So you call them beta lactamase inhibitors. And actually, when you are giving beta lactamase inhibitors, remember what is their role. So beta lactamase inhibitors. Their role is basically to prevent the destruction of these cell wall synthesis inhibitors when they are given because they can be destroyed. Most of them have got a beta lactam ring. And so when you are giving the beta lactamase inhibitors, please also give the cell wall synthesis inhibitors because they will not be broken down. And examples there we have got what is known as cluvulanic acid or cluvulamate, and when you are giving this guy actually clavulamic acid. So when you give this guy, you are supposed to give also amoxicillin because it will simply prevent the destruction of amoxicillin. This is the only one that is ending in a special form like this, but most of these, the beta lactamase inhibitors, they end in bactam, like saubactam. So when you give saubactam, you're also supposed to give ampicillin. And then you also have tazobactam. You can see how they end. Those are beta lactamase inhibitors. Really easy, isn't it? And then another one that we need to know now. I think the only thing that we should know about cephalosporins is that they have got they are in generations, first generation up to fifth generation. On the fourth generation, you only have one drug, cefapine. I think that's the only thing that I can mention here. Yeah. And then for the you also have carbapenems, they end in penem, like imipenem, meropenem, etapenem. So these carbapenems, they are resistant to beta lactamase. Take note of that. This beta lactamase enzyme, which was down the cell synthesis, which was breaking down the penicillins, it will not destroy the carbapenems. That's why they are good. And of every antibiotic drug, the carbapenems are actually the best when it comes to being wide spectrum. They have got the widest spectrum. So these guys, the carbapenems, are active against gram positives, gram negative, anaerobics, and every other. And then you have got macrolides. Macrolides, these guys are going to be used specifically, they are going to be binding to the 50S subunit, that's a macrolide of the ribosome. And you want to give them specifically in those patients that can't respond to penicillin, maybe because of an allergy or there is resistance. So macrolides you give them in that case. You have got drugs like erythromycin, clarithromycin, azithromycin. So those three. I'll just put A, actually AEC, erythromycin, azithromycin, clarithromycin. These are examples of macrolides which bind to the 50S subunit. And then aminoglycosides, remember what I mentioned? Autotoxicity is the biggest problem of these guys. Okay, that is what you want to prevent. And for the aminoglycosides, you basically inject them. You inject them. And the aminoglycosides are also in generations first, second, third. Please just take note you have got one aminoglycoside which is known as streptomycin. You can see they are also ending in the same way like the macrolides because they are also ending in mycin. Please don't confuse them. So streptomycin specifically binds to the 30S. These guys, the macrolides like erythromycin and the others, we are binding on the 50S subunit. And then monobactams, one thing you need to know about monobactams is that only effective against gram negative aerobes. Please take note, only monobactam gram negative aerobes like Neisseria and Pseudomonas. So basically that is it that I needed to mention on antibiotics, and then we can now go on and answer our questions. That is a good summary for both pharmacology and microbiology. For much more detailed details, we can now get to just read that. Let me just mention one thing before we start answering the questions on those guys which are inhibiting the synthesis of folic acid. You know, the folic acid has got its own pathway. You have got what we call dihydropyridine pyrophosphate, dihydro, how do I even shorten it? Dihydropyridine pyrophosphate. This guy can be converted into dihydroteroate. So we are basically looking at the pathway for the synthesis of folic acid. So we start with dihydroteroate diphosphate. Let me write this properly. It is just the three steps, not long. So what we should just know is that we are starting with dihydroteroate. It's teroate that starts with a P, diphosphate. So we're going to react this guy with para amino benzoic acid. When you react these guys, you are going to form dihydroteroic acid. Please take note, you are forming the acid, or dihydroteroate. And here you have got the enzyme dihydroteroate synthase because that's what you are forming. So what can inhibit this enzyme is the sulfonamide. And then the dihydroteroate or teroic acid is going to go to tetrahydrofolate or tetrahydrofolic acid using the enzyme tetrahydroreductase, and the enzyme is a reductase. The enzyme that inhibits this one is trimethoprim. So these are the two guys that inhibit the synthesis of folic acid. Okay, just these. One is inhibiting the formation of dihydro, dihydroteroate, which is the sulfonamide. Trimethoprim is inhibiting the synthesis of tetrahydrofolate. Renal damage is a potential adverse effect of aminoglycosides. In what part of the kidney are aminoglycosides retained? Question is just saying where in the kidney do you have the reabsorption of this drug? Anyone that can help us with that? This one I think is just something that we should know. Anyone? Thank you so much. So in the proximal tubules, that's where aminoglycosides are retained. This drug can kill most aerobic bacteria and aerobic protozoa, but causes a disulfiram-like reaction in people who concurrently consume alcohol. Which drug is associated with disulfiram-like reaction? Anyone? Metronidazole. Thank you so much. Clovan, clavlanate, which is clavulanic acid, is combined with amoxicillin for the following reason: preventing allergic reactions, improve palatability, prevent beta lactamase degradation of amoxicillin, decrease side effects. Anyone to help us with that one? Anyone? Okay. So if you type, I'll not be able to see the typing. Thank you so much. Beta lactamase. Remember, clavulanate is a beta lactamase inhibitor, which is preventing the breaking down of penicillins. A patient is treated with vancomycin for methicillin resistant Staph aureus infection. Which of the following mechanism explain the action of vancomycin? Disruption of cell membrane integrity, inhibition of protein synthesis, inhibition of nucleic acid synthesis, inhibition of cell wall synthesis. Anyone? So the first thing first that we need to know is when we are saying vancomycin, what class of drug is it? Anyone that knows the class of drug in which vancomycin falls? So I didn't mention this. Vancomycin is, yes, it's like the only glycopeptide, and these guys, the glycopeptides. Anyway, someone can mention what is the mechanism of action for glycopeptides. I didn't give it when I was giving the others. Inhibition of protein synthesis. B or D? I've not gotten that properly. Can you come again, please? Okay, so the doc has said B. Anyone that has got another option? D. Okay, D, not B. All right. Thank you so much. So it is the inhibitor of cell wall synthesis. Okay. So we have got two: inhibition of. Now for proteins, I think it is, isn't it? We said it's MAAOT, and this there is no G there. So it is also an inhibitor of cell wall, like the penicillins, the cephalosporins, the carbapenem. A 40-year-old male with bacterial prostatitis is prescribed with fluoroquinolone. Which of the following is a common side effect of fluoroquinolones? Allergic reaction, neurotoxicity, hepatotoxicity, tendon rupture. Anyone? So for fluoroquinolones, what this class of drug is specifically going to work in the inside of the cell, and what it does is that when you are when the DNA replication is happening, you have got an enzyme. Remember, DNA is like this. So before you can start making a copy of DNA, you need to make it straight. We said to remove supercoils, so you make it like this. When you make it like this, and then the enzyme helicase is going to come in to now start dividing it, and then DNA polymerase will come and start making a copy. So you have got an enzyme that removes supercoils, and that's known as topoisomerase, also known as DNA gyrase, and that is the mechanism of action of the fluoroquinolone. So meaning that since they are inhibiting DNA gyrase or topoisomerase, they are going to disturb DNA replication. And one side effect that is always, whenever you see tendon rupture, always think of fluoroquinolones. Okay. Which of the following is a penicillinase resistant penicillin? Penicillinase resistant penicillin. Azithromycin, cefepime. This is actually the fourth, it's the only fourth generation cephalosporin. Ampicillin, cloxacillin. Anyone to help there? Anyone? Ampicillin. Okay, let me mention again. Remember when we talked about the penicillins? We said the many ones, the first ones, like the first you have got pen G. From pen G, something else was made, which is actually just better when it comes to oral absorption, which is pen V. And then you have got penicillinase resistant. Those because pen G and pen V can be broken down penicillin. So methicillin and those guys that end in sacillin, like cloxacillin, nafloxacillin, those guys are penicillinase resistant. And then you have got extended spectrum penicillins. That's where I've got the A's, aminoglycosides, ampicillin and amoxicillin. So which one is the answer now? Thank you so much. So it's cloxacillin. Tendon rupture. This drug is effective against HAV1 but not HIV-2. Okay, real something real quick so that we just understand something about HIV. HIV is is icosahedral, meaning that it has got like eight shapes. Is it eight shapes or eight sides? Icosahedral. And then it has got the envelope going inside is going to have a capsid, and then you have got DNA, not DNA but RNA, and it has got single single stranded RNA, which is positive sense, meaning that the RNA that it has, you can direct use it as a strand to make, remember this is RNA, okay, and for RNA specifically mRNA, it can be converted to proteins. So if you say that this guy is positive sense, it has got positive sense RNA, it means that its RNA can act like mRNA, which you can use to form proteins. But those which are negative sense, you are first going to convert it to a strand that is complementary, that is going to look like mRNA, and then you can now form proteins. And specifically, we know that the virus, the HIV virus, has got three important proteins. It has got integrase, it has got reverse transcriptase. Which one is the third one? Anyone to help? It has got also the protease. So what is happening is here is, remember this guy has got mRNA. When you get DNA, you take it into RNA. We call this as transcription. And the transcription, because we are forming RNA, works by what we call RNA polymerase. But then, since this guy, the HIV, is RNA, so we first going to get its RNA, we convert it to DNA using the reverse transcriptase. It's also known as RNA dependent RNA polymerase because it's working on RNA. And then when we form the DNA, the DNA now is going to, because the first thing is that this guy, let's say this is our host cell, this is our cell. This guy is going to come here and bind to our cell so that it can enter inside. So at this point, we can give a drug that can prevent the entry of the virus. So we have got entry inhibitors. Specifically, this guy has got GP120, GP41. GP41 is transmembrane, it runs through the cell membrane. GP120 is on the surface here, it is used to attach to our cells, specifically attaching to the CXCR5, and is it the CC something? There are two of those guys on the macrophages and these other cells of our body. When this guy enters, we are now going to convert RNA into DNA using the enzyme DNA reverse transcriptase. So other drugs that we can give will be to inhibit the conversion of RNA to DNA. So this is number one. So number two be reverse transcriptase inhibitors. And then when we get to form the DNA, this DNA of the virus is now going to be incorporated into our DNA. And then when it is incorporated, now we are going to start making, remember when you have got DNA, you are now going to go back and form mRNA again. This mRNA contains our own proteins and our own mRNA and the mRNA of the virus. But we are using the RNA polymerase of the host and not for the virus. When we form this mRNA, we can now go and form the proteins. Now, these proteins have to be cleaved. These will include also the viral proteins, like this same integrase, reverse transcriptase, and these others. When we just formed the DNA, to prevent that DNA of the virus from integrating with our own DNA, we could have used the integrase inhibitors. And then just these proteins that we have formed, to prevent them from breaking them down to become effective, we can use the protease inhibitors. So those are the classes of drugs. Now specifically, we have got the reverse transcriptase inhibitors, preventing this enzyme. We have got those which are looking like nucleosides and those which are non-nucleosides. So I've got non-nucleoside reverse transcriptase inhibitors and the nucleoside, meaning that they appear the same like the cytosine, the guanine. Specifically for the non-nucleoside reverse transcriptase inhibitors, you only use them for HIV-1 because they can't work against HIV-2. For HIV-2, you can use these other classes of drugs. So just that is what we needed to know. Yes, please, doc. Okay. Anyone, anyone that wants to help with that question? Why do you think we can't use the non-nucleoside reverse transcriptase inhibitors for HIV-2? They can only work for HIV-1. Anyone? Anyone to help? All right. So for the nucleoside reverse transcriptase inhibitors, these guys, I don't know if there's any special feature that enables them to work only against HIV-1 and not against HIV-2. But just that is just one important property that these NNRTIs have, just working against HIV-1. So the way they are working is that they are non-competitive inhibitors of HIV-1 reverse transcriptase itself specifically. So they do not compete with nucleoside triphosphates and they don't require any phosphorylation. So they are specifically against HIV-1 reverse transcriptase. Obviously, it should have some special features which have not taken keen interest to find out. Is that okay, Doc? Actually, even in their notes, they've not specified why it's against HIV-1 only. The patient has a peptic ulcer disease caused by H. pylori, and the physician is looking for a macrolide effective against both H. pylori and Mycobacterium avium complex. Which of the following macrolides will be the first choice? Clarithromycin, telithromycin, azithromycin, erythromycin. Anyone that can help with this? Anyone? Anyone? A? Any thought why, Doc? Any thought why it should be A? Okay. So specifically when you are looking at peptic ulcer disease, you know this guy is caused by H. pylori. And we have got what is known as the triple therapy and the quadruple therapy when you are treating peptic ulcer disease. For the triple therapy, specifically what you want to use a proton pump inhibitor, maybe you can get omeprazole, and then you are going to get one macrolide. Specifically, the macrolide that we use is a clarithromycin. And then you can either get amoxicillin, which is a beta lactam, or it's a penicillin actually, we know that. So you can get now another penicillin like amine, you can get amoxicillin, you can as well get metronidazole. You know metronidazole is going to interfere with the making of DNA, and so that prevents the growth of the bacteria. So you can either use metronidazole or you can use the amoxicillin. So these guys, metronidazole or amoxicillin, are basically trying to prevent the growth of you are trying to destroy the bacteria. And the clarithromycin, it being a macrolide, we know how the macrolides really work. They are trying to prevent the synthesis. They are trying to prevent the synthesis of your nucleic acid, like by binding to the 50S subunit. A proton pump inhibitor preventing the production of the acid. So that's how it's going to work. For the quadruple therapy, here you are using four things. You can either use a proton pump. Now you can as well substitute the metronidazole or amoxicillin with a tetracycline. Take note of that. So you can use a proton pump inhibitor, or you can use a H2 antagonist. because remember your histamine promotes the production of acid. So whether proton pump inhibitor or histamine, and then you can now combine this with bismuth, which you know is going to, if you have got an ulcer there, it will just be there, more like shooting this ulcer. And then when you have got a lot of acid there, you are preventing this acid from destroying your cell. That's the bismuth. Another thing that you can use is a tetracycline, and then you can as well use a metronidazole. So this is what you combine when it comes to the quadruple therapy. Either choose PPI or H2 antagonist with these three. Okay. So specifically, clarithromycin is the macrolide that we use. Which of the following is a drug of choice for typhoid fever and anthrax? Cotrimoxazole, ciprofloxacin, ampicillin, chloramphenicol. Anyone to help with this one? Typhoid. Typhoid fever. This guy is caused. Anyone that knows the cause for typhoid fever? Yes, Salmonella typhi. So you are basically trying to look for a drug that is going to work against this guy. And yeah, basically that, nothing more. So we have got cotrimoxazole, ciprofloxacin, ampicillin, chloramphenicol. Anyone now that can help us? Okay, B. Why do you think so, Doc? Is that one where you just need to sort, isn't it? So for salmonella type, the drug of choice is ciprofloxacin. It has got high efficacy, it has got good oral bioavailability, and there is a low resistance. It is actually a fluoroquinolone, ciprofloxacin. Okay. Next question. Now, in case you want to know again, fluoroquinolones, these guys are broad spectrum. We already mentioned they are going to inhibit the synthesis of, they are going to inhibit the enzyme topoisomerase. A 32-year-old woman is prescribed trimethoprim for urinary tract infection. What is the common adverse effect with the trimethoprim? This guy is an inhibitor for folic acid synthesis. Anyone? Hepatotoxicity, tendon rupture, anemia, ototoxicity. Would you want to explain why, Doc? Or anyone that wants to explain why trimethoprim leads to anemia? Thank you so much. Basically, that, remember we said that in the pathway for folic acid, you want to prevent tetrahydro to produce tetrahydrofolate using the hydrofolate reductase. And this guy, you know that folic acid is, this is active form of folic acid, and this guy is actually good for what? Folic acid is used in the synthesis of, okay, one thing that we know is that when someone doesn't have folic acid, because folic acid is used in the synthesis of DNA, and that is going to be used in the making of your blood cells. So actually, the inhibition of the production of tetrahydrofolate doesn't only cause the reduction of red blood cells, but all blood cells. because you need DNA and RNA in all of them. So there's going to be anemia, there's going to be thrombocytopenia, there's going to be also the reduction in the white blood cells. A 55-year-old male with bacterial prostatitis is prescribed fluoroquinolone. Which of the following best describes the spectrum of activity of fluoroquinolones? Narrow spectrum effective against gram negative, narrow spectrum against gram negative. What's the difference between A and B? And then C, broad spectrum effective against both gram positive and gram negative. Broad spectrum effective against anaerobic. Anyone to help? Thank you so much. Remember, this guy that is inhibiting gene agarase is effective against every type. A pharmacology student is studying the mechanism of action of antibiotics, which antibiotic inhibits protein synthesis by acting at the 30S ribosomal subunit. 30S macrolide, tetracycline, chloramphenicol, penicillin, penicillins. Anyone? Anyone to help with that one? So specifically for the guys that are preventing protein synthesis, we said we have got MALT, right? MALT. So you have got some which are preventing protein synthesis by working on the 30S ribosomal subunit. Others are working on the 50S ribosomal subunit. So on the 30S, I think some important ones that we need to know are the tetracyclines. Even this one already mentioned, streptomycin, the strepto guy, which is an example of which class of drugs? Aminoglycosides. And then erythromycin is a macrolide, and we said erythromycin was falling here on the 50S. Others on the 50S, most of the macrolides. Also, chloramphenicol is a common drug which is going to fall here. Clindamycin, lincomycin, and then others on the 30S. Apart from, we also have, apart from the strepto, and I think these are the common ones, tetracycline, these are the most common one. Also gentamicin, these are common ones that we can know here. Yeah, we also have a drug that is a very common liver enzyme inducer, rifampicin. This is rifampin. Hope they are different. Rifampicin is a liver enzyme inducer. I hope they are the same, but this guy inhibits just the DNA, the RNA polymerase. So we want to prevent the making of RNA. So we can see there is a tetracycline. A patient with severe infection caused by beta lactamase producing organism is treated with a beta lactam antibiotic. Which of the following antibiotics would be the least effective in this scenario? Patient with a severe infection caused by beta lactamase producing antibiotic is treated with beta lactam. You know the beta lactam antibiotics, actually all these guys mentioned here. Which of the following antibiotics should be the least effective? Aminopenicillins, cephalosporins, carbapenems, monobactams. Anyone to help? A, thank you so much. Why would you go for A? Okay. Thank you so much, Doc, for that. Anyone that wants also to say what they have? Okay. As the doc has said, let me just add something, maybe just to make the point more clear. These drugs that we can see here have got a beta lactam ring. They have got a beta lactam ring. So those bacteria that produce the enzyme beta lactamase, that means that these drugs can't be effective against those bacteria. Why? Because they are going to be, when you give the drug, because all these drugs have got a beta lactam, that drug is going to be destroyed by the lactamase. Okay. But then let's get the question back. A patient with severe infection caused by beta lactamase producing organism is treated with beta lactam antibiotics. So the following antibiotics would be the least effective. So of the beta lactam, these bacteria that have got a beta lactam ring, most of them are actually going to be resistant to this beta lactamase. Even when the bacteria produces the beta lactamase, they are going to be resistant to that beta lactamase even when they have got a beta lactam ring. But for the penicillins are really poor. They are not resistant to the beta lactamase. And an example of a penicillin are these aminopenicillins like amoxicillin and ampicillin. Hope that is fine. Which drug is preferred in onchocerciasis chemoprophylaxis with high efficacy against ectoparasite such as head lice? Plasquanta, albendazole, ivermectin, mebendazole. Anyone? Remember the biggest word here is prophylaxis. I think there's just one, isn't it? One or two? Prophylaxis of onchocerciasis. So which one? Praziquantel, albendazole, ivermectin, mebendazole. Okay. So ivermectin is very good when it comes to chemoprophylaxis. How does it work? So let's quickly describe these guys. When it comes to these helminthic infections, if we start with Praziquantel, it's also known as butyricide. It's effective against cystodes and trematodes. Cystodes plus trematodes. This is where this guy is effective. And we know when you're talking about, anyway, I believe we can still remember. So for the cystodes are also known as tapeworms. Examples include like tinea, Diphyllobothrium latam, Echinococcus granulosus. Those guys are cystodes. And then the trematodes, these will include things like cystoma. So the cystodes and trematodes, trematodes are flukes. Cystodes are tapeworms. These two classes, the cystodes and trematodes, make up what we call the flatworms, the platyhelminths. So basically, Plasquanto is against the platyhelminths. How it works is that it's going to increase the permeability of the cell membrane to calcium. And when calcium is entering the cell, there's going to be increased muscle contraction, and then that is going to cause death of the organism. Okay. And when you give high doses of Praziquantel, it's going to be, you're going to kill a lot of these worms such that they are going to release a lot of antigen. And those antigens, a lot of them that are released, are going to cause an immune reaction. And so that's a problem when you give Plasquanto in high amounts. Plasquanto is very much effective against, as we've said, the flukes, which are the trematodes. So it can be used in blood fluke infection, that is cystomiasis, liver fluke, that is fasciola hepatica, that is liver, and then also lung fluke, that is palagoniasis. So against the flukes, more especially, also the cystodes, of course. Adverse effects: headache, nausea, inflammatory reaction because of the dead parasites you are trying to react to with them. So because of that, when you give Plasquanto, you're supposed to give also corticosteroids because of that inflammatory reaction that can be produced. And then you also have these guys, these two, mebendazole and albendazole. Sorry for that. Mebendazole and albendazole, these guys, they are known as the benzimidazoles. How they work is that they are going to bind to the beta tubulin of your worm. That will mean that when they bind to the beta tubulin, they are going to prevent the beta tubulin molecules from coming back together. That is coming together, and that's known as polymerization. So there's not going to be any polymerization, and they are going to impair the uptake of glucose by the worms. Specifically, they work against the nematodes. Now you know that nematodes are roundworms. You have got those which are intestinal, like the vermicularis, trichulias, ascaris, ancylostoma duodenale, strongyloids, and then you have got those which are in the tissue, like Unchelela, loa. So those are examples. So they are impairing glucose uptake, and because the worm is not taking in glucose, there is no ATP production, and that to make the worm to be immortal, and then it's going to be dead. Okay. So our benders, one thing we need to know about our benders is that it is going to be used for neurocysticosis. Like, it is good because it can penetrate through the blood-brain barrier. It is a bit more lipid soluble than mebendazole. So mebendazole can't penetrate the central nervous system. That's why you can't use it for neurocysticosis. Albendazole. So when you are giving these drugs, because both of them, even when our bendazole can penetrate the blood-brain barrier, it is still not that fat lipid penetrating. So you give them together with a fatty meal so that you increase their absorption. So just some problems that you see with these guys is that in short-term therapy there will be some GIT problems, and then they can also be CNS problems later on, like even condition like agranulocytosis, alopecia. So someone starts losing their hair. Can also be, it is teratogenic in animals. So it is only used in pregnancy after risk benefit assessment. You don't want to give it anyhow because it is bad. Teratogenic proven in animals. Okay. You also have another drug of this class which is known as the thiabendazole. So thiabendazole, this guy has got a wide nematode spectrum, but has got high toxicity. That's why it is not used very much. And then the last one, the last drug I want to mention is the same ivermectin, also known as meclizan. The mechanism of action for this guy is that it's going to bind to glutamate activated chloride channels in the muscles, and that is going to lead to chloride influx. So basically, it causes hyperpolarization, and that leads to ionic paralysis of the nematode. Please take note: ionic paralysis of nematodes is also working against nematodes. Specifically, ivermectin doesn't work against the old ones. It is only working against the babies, the baby worms. Okay, so that's why it is used. So we those baby worms we call them microfilaria. before they can even be released from the uterus. So it is used for prophylaxis. It's actually a drug of choice for onchocerciasis, lymphatic filariasis, and tropical pulmonary eosinophilia, which is caused by Wuchereria bancrofti. So basically, that I think for these drugs against that's the pharmacology of these drugs against the worms. What is the main aim of treatment in osteomalacia? To restore vitamin D and parathyroid hormone levels, to restore serum calcium levels only, to restore serum phosphate levels only, to restore serum calcium and phosphate. Anyone to help with that? Anyone? Now, osteomalacia is a condition where you have got weak bone. Obviously, when a bone is weak, it means that you don't have enough calcium, isn't it? And what happens is that when the body has got low calcium, it is going to stimulate the parathyroid gland to produce parathyroid hormone. Parathyroid hormone is going to go to three many places, to go to the kidney, and in the kidney it is acting on alpha 1 hydroxylase to cause the conversion of calcidio to calcitro 25 hydroxycholecalciferol to 1,25 dihydroxycholecalciferol, which is active vitamin D. And then that guy, the active vitamin D, is going to go to the intestines to cause the absorption of calcium from the intestine. I mean, the absorption of calcium from the food. Besides that, it also work on the kidney to cause absorption. Yes, please. Oh, I'm break. Okay. So you can simply try to check the network, doc. So on the kidney, we've said two things. It will increase absorption of calcium and the excretion of phosphate. That's why parathyroid hormone leads to phosphaturia. And then it's also activating vitamin D. When vitamin D goes to the intestines, it causes absorption of calcium. So you're trying to increase calcium in blood because it's low. It will also go to the bone. And in the bone, what you're basically doing is that you are breaking down bone so that you release a calcium to go into blood to restore the calcium. The reason as to why we are actually we are excreting phosphate is because phosphate, when it is there in the blood, it binds to calcium to form the hydroxyapatite, which has got calcium and phosphate. And so it will still, the body will still record that you have got little calcium. The opposite of this is going to be true when you have got high calcium. So meaning that when you have got conditions of weak bone like osteoporosis, you want to deposit calcium into the bone, isn't it? So the opposite hormone that will be working is calcitonin, which is going to be trying when you have got too much calcium in blood to reduce the calcium in blood. So in conditions where there's calcium disbalance, you are trying to work between calcium and phosphate to restore their normal levels, both of them. Same with osteomalacia, where I've got weak bone, obviously, because the calcium has been removed from bone. So I want to work on restoring the normal levels of calcium and phosphate because these guys, you can see the way they are, they bind to each other. Narrow spectrum penicillin, both penicillin sensitive and resistant, have relatively poor activity against gram negative bacteria to restore serum calcium and phosphate levels. Narrow spectrum penicillins, both penicillinase sensitive and resistant, have relatively poor. Yeah, it's being excreted. That is in the kidney, and the main aim is you don't want it to bind to the calcium. But it's still more because you have got weak bone, right? when you want to have a strong bond, calcium and the phosphate are supposed to be together to form what is known as hydroxyapatite, and that is what makes bone strong. So one of them alone will not be able to help in osteomalacia. Is that okay? All right. So narrow spectrum penicillins, pen, both which are penicillin is resistant and sensitive, have relatively poor activity against gram negative. What is the many property or characteristic that explains why these microorganisms do not respond well to penicillins? Why do gram negatives don't respond well to penicillin? A. Metabolically inactivate these penicillins by mechanisms not involving beta lactam. B. Actively transport any absorbed penicillin back to the extracellular space. C. It has an outer membrane that serves as a physical barrier to penicillins. D. Lack of penicillin binding protein. Anyone to help here? Anyone? Actively transport any absorbed penicillin back to the extracellular space. So if we can pick B, so we should be thinking of why don't gram positives do it? Why don't the gram positives take back the calcium to the extracellular space? D. Lack of penicillin binding protein. So remember the, yeah, so let's also think about D. If we picked D, we would ask ourselves, why don't the gram positives behave the same? Because these guys both have got a cell wall and a cell membrane. Specifically, penicillins are cell wall inhibitors. So why are we really not binding? Because gram positives and gram negatives both have got a cell wall. So if they have got both a cell wall, it means that there should be a receptor on both of them that is going to prevent the binding, right? So when you look at the structure of gram positives and gram negatives, for gram, let's start with gram positive. Let's say this is the plasma membrane. You know it is a double layered structure. That's the plasma membrane. And then you have got a cell inside. Okay. Actually, first you have got, before you can have the cell, the cell is supposed to be inside. So this the cell membrane is supposed to be inside. So let's say this is the cell wall, and you know the cell wall has got peptidoglycan, and then you have got the cell membrane inside. For gram negative, this is G positive. For gram negative, they have got a cell wall here, they have got a cell membrane, and then they have got another cell wall. So you can see these guys have got two cell walls. And the way penicillins work is that they are trying to destroy the cell wall. So the problem is here, an outer membrane that serves as a barrier, as a physical barrier to the penicillins. So there is actually thickness of the cell wall when it comes to the gram negatives, and that is acting as a barrier. Imagine, let's say you are targeting this membrane here, this cell membrane. So the first one is acting as a barrier. So if the penicillin came, it might be acting on this one on top, and then it won't go to the one inside. Or if it's trying to go to the one inside, this one on top is acting as a barrier. But that's different for the gram positive because there's only this membrane which you'll be able to attach to, and then the mechanism of action happens. Yes, please. Okay, actually, the reason is just here. It has an outer membrane that serves as a physical barrier to penicillins. Because of the outer membrane is serving as a barrier to the penicillins for them to enter. And I'm guessing that same outer membrane they're mentioning is the outer cell membrane because you have got also the inner cell membrane. Sorry, the cell wall. Because you only have one cell membrane. And if you compare the cell membranes, the one for the gram positive is even actually thicker cell membrane than the one for the gram negative. But then these penicillins are not working against a cell membrane, they are working against a cell wall. So because of that outer one, it is acting as an obstruction. Hope that makes a bit sense so that we'll be able to remember it. Thank you. Number 17, a 30-year-old male presents with a skin infection caused by methicillin resistant staph. Which of the following is the most appropriate treatment option? Tetracycline, vancomycin, benzophenylcycline, amoxicillin. Anyone to help? Vancomycin. Thank you so much. Remember, vancomycin is a glycopeptide, and glycopeptides are working preventing against this synthesis of your cell wall also. Which of the following is the action of the parathyroid hormone on the kidney? Action of parathyroid hormone on the kidney increases reabsorption of phosphate, decreases reabsorption of calcium, activates calcitonin, activates vitamin D. Anyone? Anyone to help with that one? We remember we've already mentioned this, right? Two steps above. It's here. Okay. Okay. Let's get from anyone that thinks an option before we can also mention so that the dog can get it. Anyone? Remember I've said there are three basic effects of the parathyroid hormone. On the kidney, you are doing two things. Number one, you are activating one alpha hydroxylase that is converting that is converting 25 hydroxycholecalciferol to 1,25 dihydrocholecalciferol. The first one I've mentioned is also known as calcidio. The second one that you are forming is known as calcitrio. That is the active form of vitamin D. So you're activating vitamin D. The second thing is that you are causing absorption of calcium and excretion of phosphate, phosphaturia. On the intestines, the same vitamin D that you have activated will go to the intestines to cause absorption of calcium. Absorption so that it increases. You also go to bone because calcium is low in blood. You are going to start breaking down bone so that you form calcium. So, parathyroid hormone is going to cause osteoporosis, weak bone, because you are breaking down bone. So, which one is the answer here? Thank you so much. A 50-year-old male with pneumonia is started on cephalosporins. Which of the following mechanism of action do cephalosporins share with penicillin? Protein synthesis inhibition, folic acid inhibition, cell wall synthesis inhibition, nucleic acid. Thank you so much. Cell wall synthesis inhibition. Which of the following benzimidazoles has less than 10% oral bioavailability and low lipid solubility? For this reason, it is not preferred for neurocystic treatment. Praziquantel, ivermectin, albendazole, mebendazole. Anyone? We are also from mentioning this guy, isn't it? Thank you so much. Remember, we said albendazole can be used because in neurocysticercosis because it can penetrate. A patient is being treated with a broad spectrum penicillin. Which of the following is a characteristic of aminopenicillins like amoxicillin? They are resistant to beta lactamase. They have a narrow spectrum of activity. They are only effective against gram positive. They are able to they are stable to gastric acidity. Anyone? Any thought? Let's start with A. They are resistant. We can start with A in case people are getting it hard to. They are resistant to beta lactamase. Is that true? This is false. They have a narrow spectrum of activity. Is that true? This is false. Remember, we said the only guys with which have got a narrow is the penny G and its friend penny. They are only effective against gram positive. Is that true? Since they are not having a narrow spectrum, so they can't be effective only against that. So the remaining one is true, isn't it? They are stable. That's why we can even give them via the mouth, oral, because they are stable against gastric pH. They will not be destroyed in the stomach. Ampicillin and estrogen progesterone combination oral contraceptive therapy should not be given together. Why? Let's start. Ampicillin, what class of drug is it? Ampicillin. We are from mentioning it on top. Thank you so much. It's actually a penicillin, an aminopenicillin, a cell synthesis inhibitor. Thank you. So why should you not give it together? And you know these guys, what are they doing? They are destroying bacteria. And you know you have got some normal flora bacteria right in the body. So reduced effect. Why should you not give them together with estrogen and progesterone for contraception? Maybe if you give them together next time a person comes pregnant, why were they pregnant? So reduced effects of the hormonal contraceptive due to reduced gut flora affecting enterohepatic recirculation of the contraceptive. B, the effect of the antibiotic was reduced because of the contraceptive enhancement of the liver enzyme, causing a lack of effect. C, if increased effects on the antibiotics are due to the inhibition of the hepatic metabolism of the antibiotic by the hepatic enzyme, causing toxicity. D, increased effects of the hormonal contraceptives by inhibition of the hepatic metabolizing enzyme, causing toxicity. Any thought? Okay. Anyone with a thought, anyone with an idea. So the problem here, imagine you give someone an antibiotic, and then you give them also contraceptives. So antibiotics are destroying bacteria, and you know that in the gut you have got normal flora, and specifically aminopenicillins like ampicillin. These guys have got wide spectrum activity. So besides them only destroying the bacteria that is problematic, they also destroy the good bacteria in our stomach, and that is going to affect the enterohepatic circulation, because from your GIT, in the GIT we have got this bacteria, so we have destroyed the bacteria, and the GIT is connected to the liver, right? So because you have destroyed this bacteria, which acts also as a form of antagonist to other things that you are bringing in the body, there are no those antagonists. Even to the drugs, there are no those antagonists like the oral, the estrogen, and the progesterone, meaning that they can be more absorbed or that, and they'll be taken to the liver. To the liver, when they go there, they'll be broken down and they might not be effective. So someone comes next time they're pregnant. How come? It's because they were made ineffective. Which of the following is a drug that shows no cross allergicity with other beta lactam antibiotics? Ampicillin, which is a penicillin, azithra- azithromycin, which is a monobactam, cloxacillin, which is a penicillin, and cefepime, which is a fourth generation. Thank you. Previous one, it was A, reduced effect of the hormonal contraceptive because of the reduced gut flora affecting enterohepatic circulation of the contraceptive. So, Doc, would you want to explain why you've gone for B? Thank you so much. And that's that. Penicillins, cephalosporins have got similar structures, and so even the problems are the same. Monobactams are better, will not show any reactivity, cross reactivity. Which antibiotic can lead to gray baby syndrome in neonates due to inadequate glucuronidation? Chloramphenicol. And this guy is an inhibitor of what? We said what? That's a 30S, isn't it? Doxycycline, which is a tetracycline. Gentamicin, aminoglycoside, and erythromycin, which is a macrolide. Anyone with a thought? Chloramphenicol is actually 50S inhibitor, not 30. Anyone? Okay, about gray baby syndrome, you need to know this is specific. Just like we talked about the tendon rupture being also specific. Gray baby syndrome is specific to chloramphenicol, which is a 50S inhibitor. This guy will prevent one structure, sorry, one enzyme. It is going to inhibit one enzyme known as UDP glucuronil transferase, which glycosylates this enzyme in children, which glycosylates this drug in children. So because of that, you are not breaking this drug down. There's going to be toxicity, and that is what leads to this condition known as gray baby syndrome. Number 25. Which of the following statements is correct about the use of calcium? Chloramphenicol. Chloramphenicol is specific for this gray baby syndrome because of the toxicity. Children lack the enzyme that glycosylates the drug, and so there's that problem. Right. Which of the following statements is correct about the use of calcium supplements in therapy? Oral calcium salts require vitamin D for absorption. Oral calcium salts increase the absorption of iron, like fluorides and iron. Oral calcium gluconate is a drug of choice in hypocalcemia tetany. It may lead to hypocalcemia with long term. Anyone to help with this one? A. Thank you so much. Would you want to explain? Would you want to explain your answer, Doc? Okay. Thank you so much. So basically, for you to for you to remember, there is also supplement about the use of calcium supplement. When you are giving oral calcium salts require vitamin D for absorption. Like vitamin D is required in the absorption of calcium. That's why it is going to be produced in the kidney, goes to the intestines, specifically the small intestines, to cause absorption because it's needed. A 25-year-old female presents with a urinary tract infection and is prescribed the nitrofurantoin. Which of the following is crucial consideration regarding the use of nitrofurantoin? A is a broad spectrum antibiotic. B, it is stable to beta lactamase. C, it should not be used in patients with renal impairment. D, it is effective against all gram-negative bacteria. Anyone to help with that? So nitrofurantoin is a drug that is used in urinary tract infections against gram-negatives like Pseudomonas aeruginosa, Klebsiella, Proteus, E. coli, staph. We know staph itself, like, is not staph saprophyticus is not gram negative, but those are some special ones that it can also treat, like E. coli, staph saprophyticus, and Enterococcus fecalis, specifically UTI. And the bigger problem that you face with this drug is don't give it because it's excreted in the kidney. So don't give it when someone has got problems with the kidney. How does it work? It prevents the synthesis of DNA, RNA, and also the synthesis of proteins. So the answer is C there. Don't use it in patients with renal problems. Which of the following antibiotics can interfere with bone and teeth development in children? Erythromycin, which is a macrolide, gentamicin, aminoglycoside, levofloxacin, quinolone, doxycycline, tetracycline. Anyone? This one I want you to remember it as T is equal to T. So which one can you pick? D. Thank you so much. So tetracyclines, what they do is that they impair calcium absorption. And what they do is it is specific. This one is specific, just like we talked about tendon rupture, we talked about great baby syndrome. You are going to see when you look at children, the teeth will permanently change the color, like they become brown permanently. For adults, maybe because the teeth is still growing, it might not be permanent, but then there will still be some problems with the teeth, the color. So that is tetracyclines. Every time you hear of teeth change, acute tonsillitis caused by gram-positive bacteria may be treated with amoxicillin. Which molecular action most likely contributes to the drug's therapeutic effect? Again, let me mention what class of drug is amoxicillin? Anyone? Pardon? Thank you so much. Cell wall synthesis inhibitor. So now what we want to understand is how is it preventing the cell wall synthesis? So which molecular action most likely contributes to the drug therapeutic effect? A. Inhibition of DNA dependent RNA polymerase. In activation of autolytic enzymes in the bacterial cell wall. C. Activation of the efflux pump in bacterial cell wall, cell membrane. D. Binding of the 30S bacterial ribosome subunit. Anyone? B, thank you so much. You can see it's the only one talking about cell, right? So actually what it does is that when it is taken up by the cell wall, it is going to activate enzyme that will start breaking down the cell wall. Those are autolytic enzymes. 29, we are remaining with 5 questions. Is it 5 or 4? Aminoglycosides are most effective against which kind of microorganisms? Aminoglycosides. Aerobic gram positive, aerobic gram negative, anaerobic gram negative, aerobic gram positive. Anyone? Okay, between gram negative and gram positive, which one for the aminoglycoside? It's gram negative. Specifically, those gram negatives, those that love oxygen. So, which one is the answer? B. Thank you so much. So, just think of the A there and the A there, but also anaerobic, I've got A. Well, that one will now be an issue for us. But just think of hair. You need air. 30. A patient with a severe bacterial infection is given a drug that binds to penicillin binding protein. Which of the following classes of antibiotics does not belong to? Does this drug belong to? Which bind to penicillin bind? Tetracycline, aminoglycoside, beta lactam, macrolide. Anyone? Beta lactams. Why do you go for say? Any thought? I love that. So penicillins, they've got a beta lactam, and there you are going to have where the penicillin will be. So specifically, penicillins have got a beta lactam ring. Patient with severe bacteria is given a drug that binds to penicillin binding protein. So the penicillin binding protein, even from the name itself. So this is, let's say this is a penicillin, this is a drug. The bacteria that you are going to attack should have on the cell the penicillin binding protein. And then this penicillin specifically is going to come and bind. But what is helping actually it to bind? It's a structure. So besides it, penicillin is not the only guy that can bind to such drugs which have got a penicillin binding protein. Even other drugs that have got a similar structure. What is that structure which penicillins have? Is a beta lactam. A 29-year-old with AIDS was admitted to toxoplasmosis. Really? I think he was admitted for for which combination therapy was started. The inhibition of which of the following protozoal enzymes most likely mediated the therapeutic effect in this patient? Ferredoxin oxidoreductase, purine phosphoribosyltransferase dihydrofolate reductase, glucose 6 phosphate dehydrogenase. Anyone that can help with this? Taxol. What is this guy? Is this a bacteria, a parasite, a what? It's a parasite. So there is combination, you are trying to treat them with a combination therapy. So the inhibition of which protozoal enzyme mostly mediated the therapy? Hmm. Okay, just look at the enzymes. You know you have got those some common enzyme that we know. So which one do we think can be the answer? A, B, C, D. Anyone? Okay. So when you are making folic acid, you know folic acid is not only present in bacteria, it's actually present nearly all organisms because folic acid is needed by everyone. And why do we need it? We need it to be able to make RNA and to make DNA. So I've got these two enzymes, pyrithamine, which will be inhibiting dihydrofolate reductase, sulfadiazine will be inhibiting folic acid synthesis. So these guys are needed. So even when it comes to protozoa, it has no exception to needing that folic acid because it as well needs the synthesis of the DNA and the RNA. So which one can we pick? Having said at least something. C, thank you so much. A 35-year-old female with penicillin allergy is diagnosed with streptococcal infection. Which alternative antibiotic class should be avoided due to potential cross reactivity? Remember, there is this penicillin allergy. Cephalosporins, aminoglycosides, macrolides, tetracyclines. Thank you so much. And then our last question. A patient is started on trimethoprim, sulfamethoxazole for skin infection. Which of the following steps in the bacterial metabolism is directly inhibited by sulfamethoxazole? Let me mention again. Remember PABA, para-amino benzoic acid, was reacting with something, and then you are forming something that is known as dihydrotoluate using the dihydrotoluate synthase. The first guy that was inhibiting that step was the sulfamethoxazole. The second step was the dihydrotoluate being converted into tetrahydrofolate. And what was inhibiting that was trimethoprim. So we want to see which of the following steps is in bacterial metabolism is directly made inhibited by sulfur methoxide. So DNA synthesis, dihydrofolate reductase, protein synthesis, dihydrotoluene synthase. Anyone? It's D. Thank you so much. If you hear an enzyme synthase, it means that it doesn't use ATP. If it is synthetase, it means it uses ATP. So here we end. The guys to do with matching, there are a lot. So we are going to do the matching questions in the next discussion. Thank you so much.